We'll present today compressing suture technique in pediatric acute corneal hydrops. I will show two different cases of acute corneal hydrops with two different techniques of surgical compressing sutures and what is the difference in techniques about the results. My first case is female patient, 7 years old, with sudden onset of pain, redness, tearing, and photophobia, and sudden onset of decreased vision in the left eye 5 days ago, with positive family history of VKC and keratoconus. By examinations, right eye showing signs of keratoconus, when the left eye the vision was hand motion, and slit lamp examination showed marked corneal edema with stromal swelling, large central and paracentral hydrops area. Descent membrane break was visible to me, and Vandus was not visible due to edema. So what is my mindset for differential diagnosis in such cases? Actually, before I go to the next slide, you have to know that history in such cases and clinical examination is 50% of diagnosis for corneal hydrops. So my mindset differential diagnosis is that every corneal bulge equal hydrops? No, we have anterior staphyloma, and the history of the patient could answer this question. The second, every corneal hydrops equal keratoconus. We have another pathology like primary corneal or other ocular pathology like infantile glaucoma or forceps-assisted delivery. And my third question, any haze in stroma means hydrops or could be infection. Actually, not every corneal hydrops will be a clear image like that. We can have a moderate case or mild case, and you can misdiagnose it as infection or reverse it. العكس ممكن يحصل. So I asked for this case for right eye pentacamut showing keratoconus and the left eye showing by anterior segment OCT showing descent membrane break and stromal edema. So my diagnosis is confirmed now. It's acute corneal hydrops. My clues is acute onset. Descent membrane rupture is visible. Stromal edema was benign, not infiltrate. This is not infection. Eye rubbing. Other eye is keratoconus and anterior segment showing descent break. So what my plan of management, conservative treatment or compressing suture plus air injection or go for keratoplasty. And we have to know in pediatric age group, we have issues for keratoplasty. So I started actually by conservative treatment, and after 5 days, we have no improvement at all. So why rapid intervention for corneal hydrops, especially in pediatric age group? We are afraid from what? Prolonged edema could lead to strong opacity like that. The fear of amblyopia in pediatric age group is very بنخاف منه جدا. When if you do a compressing suture in early time, you can have a clear cornea after that, and you can get away from dense opacity. So I started my first case by small puncture in the stroma and milking the stromal edema. And sorry for the time of presentation, I will go a little bit faster. I started after intracameral injection to take single sutures very tight to the cornea to approximate the two edges of the descent near to each other. I take about 6 to 8 stitches in this cornea, and this is my end operation shot. What about the result in such case? After 3 days, signs of reduced stromal edema and the vision improved from hand motion to counting finger 1 meter. After 1 month, the vision improved to 360. And I don't forget the other eye by cross-linking. So after 7 weeks, after removing the stitches, I have a central scar, but the vision improved to 636 with cycloplegic once daily to overcome the corneal opacity, and ما احتاجناش keratoplasty in such case. And the really challenge in pediatric age group to reach to this smile actually was a good journey for this child. What about my second case? Shortly, it's a same diagnosis, corneal hydrops in such a case, but I take another technique for compressing suture. I started by intracameral injection. Again, start to milking stromal edema. I will fast this intracameral injection, and I start to take stitches like figure of 8 in such case. But I have a challenge after that. I will show in my next slide. The vision, after 3 weeks, the edema started to be resolved from the center, but the stitches become loose due to edema subside and become to start edema in the lower part, which another challenge in such in my case. So I go again inside the surgery and I take single interrupted suture. And after removal of stitches, the vision is corrected to 624, which is very marvelous to me. So my take-home message, acute corneal hydrops is a serious complication of keratoconus, especially in children. Eye rubbing and VKC are major triggers and must be addressed. Conservative management is the first line of treatment when the surgical option like air bubble or compressing suture for severe cases, but we have to be rapidly, especially in pediatric age group, and keratoplasty only for non-resolving cases, and don't forget the other eye. Thank you.
Very nice, Dr. Reda. Very impressive results. Very nice surgeries. My only advice would don't take photos with the patients and bring them to a conference. Don't do that, even with a consent.